In this video, we'll discuss psoriasis. Psoriasis is a common chronic inflammatory disorder that primarily affects the skin. It's caused by an abnormal immune response that leads to proliferation of keratinocytes in the epidermis, resulting in characteristic thick, scaly plaques. Let's begin by reviewing the pathogenesis. Psoriasis is likely caused by a combination of genetic and environmental factors. In genetically susceptible individuals, environmental factors such as trauma or infection can trigger the disease in part by causing keratinocytes to release cytokines like tumor necrosis factor alpha that activate dendritic cells in the skin. The dendritic cells play an important role in jump-starting the immune reaction. They stimulate naive T cells and release mediators, including interleukin 12 and interleukin 23, that cause the T cells to differentiate into T helper 1 and T helper 17 cells. The T cells migrate to the skin, where they release more cytokines, especially interferon gamma, interleukin 17, and interleukin 22. Ultimately, these cytokines not only recruit additional inflammatory cells, but also stimulate the keratinocytes in the epidermis. The stimulated keratinocytes proliferate, creating the thickened epidermal plaque. They also release more cytokines, leading to a positive feedback loop. Don't be overwhelmed by all the inflammatory mediators here, but do recognize that these pathways are important targets for therapy, as we'll discuss later. Clinically, there are several different subtypes of psoriasis, including plaque, guttate, pustular, and erythrodermic. But by far the most common is plaque psoriasis, which will be the focus of this discussion. Plaque psoriasis typically presents with well-defined erythematous or hyperpigmented plaques that are often itchy. The plaques characteristically have thick overlying silver to white scales. Removing the scales can cause pinpoint bleeding. This is called Auspitz sign and is a classic clinical finding. The plaques tend to occur in areas that are exposed to repeated trauma or friction. The most common locations are the extensor surfaces of the elbows and knees, as well as the scalp, back, and gluteal cleft. The ability of trauma to cause a psoriatic plaque is known as the Koebner phenomenon. Some patients also present with nail changes due to involvement of the nail matrix or nail bed. Findings may include pitting, yellow-brown discoloration, crumbling, or onycholysis, which is when the nail plate separates from the bed. The diagnosis can usually be made clinically, but in difficult cases, a biopsy of the plaque can be helpful. Before we dive into the histopathology of psoriasis, let's quickly review what normal skin looks like under the microscope. Here is a biopsy of normal skin. At the top is the epidermis, and underneath is the dermis. The epidermis contains several distinct layers. The stratum basale, or basal layer, contains mitotically active cells that generate new keratinocytes. As the keratinocytes mature, they are displaced into the stratum spinosum. Next is the stratum granulosum, which appears dark purple due to accumulation of cytoplasmic granules filled with protein. As the keratinocytes complete their maturation and move to the surface, they lose their nuclei and form the stratum corneum, a tough protective barrier. Over time, these dead cells are shed and replaced by the underlying cells. This entire process takes about 4 weeks. Now, let's discuss the key features of psoriasis. Here is a biopsy from a psoriatic plaque. This is the epidermis, and this is the dermis. The first finding is acanthosis, which means that the stratum spinosum is thickened. The epidermal rete ridges appear regularly elongated, like test tubes in a rack. Acanthosis occurs because the keratinocytes are proliferating faster than they can be sloughed from the surface. This is what causes the thick skin lesions to appear. The next features to remember are hypogranulosis and parakeratosis. In psoriasis, the keratinocyte maturation process is shortened to about a week. The cells are growing so rapidly that they don't have time to mature normally. As a result, the stratum granulosum is often absent, which is called hypogranulosis, and the cells in the stratum corneum retain their nuclei, which is called parakeratosis. The parakeratosis corresponds to the overlying silver-white scale. The next key finding is within the dermal papillae. The capillaries in the papillae are often dilated, and the portion of epidermis overlying these papillae, called the suprapapillary plate, is typically thin. As a result, the capillaries are very close to the surface of the skin, which is why you observe pinpoint bleeding when the scales are picked off. The last feature is intraepidermal neutrophils. Inflammatory cytokines cause neutrophils to migrate into the epidermis from the dilated capillaries, which results in the formation of microabscesses. When located in the stratum corneum, they're called Monroe microabscesses. In addition to the skin and nail abnormalities, patients with psoriasis can develop several other clinical manifestations. This reminds us that psoriasis is a multi-system inflammatory disorder that can affect multiple organs, not just the skin. One of the major associated disorders is psoriatic arthritis, which affects up to a third of patients. Psoriatic arthritis can involve the peripheral and/or axial skeleton, resulting in morning stiffness, swelling, and joint pain. In severe cases, it can cause joint destruction and deformities. There are a variety of therapies available to treat psoriasis. The specific treatment chosen depends in part on whether or not the patient has localized or widespread disease. First-line treatment is often with steroids, which reduce inflammation as well as the proliferation of keratinocytes when applied to the plaques. Many of the other available treatments also reduce inflammation. A subset slows down keratinocyte proliferation too. Of note, there are now several biologic agents available that block some of the inflammatory mediators we discussed earlier, such as tumor necrosis factor alpha, interleukin-23, and interleukin-17. These agents have demonstrated great efficacy and show how an understanding of the pathogenesis can lead to development of new effective treatments for patients with psoriasis. To sum up, here are the key points to remember. Psoriasis is a chronic inflammatory disorder that primarily affects the skin. It's caused by an abnormal immune response that leads to proliferation of epidermal keratinocytes, resulting in characteristic thick, scaly plaques. The plaques are typically located in areas exposed to repeated trauma and friction, like the extensor surfaces of the elbows and knees, and removing the overlying scales can cause pinpoint bleeding. It commonly affects the nails too and can cause pitting or onycholysis. Psoriasis is usually a clinical diagnosis, but a biopsy can be helpful in difficult cases. The histopathology reflects the rapid keratinocyte proliferation, which causes acanthosis with elongated rete ridges, hypogranulosis, and parakeratosis, as well as the increase in inflammatory mediators, which results in dilated capillaries underneath the thin suprapapillary plates and intraepidermal neutrophils. There are several conditions associated with psoriasis, including psoriatic arthritis, which can affect any joint and causes stiffness, swelling, and pain. Treatment is generally aimed at reducing the amount of inflammation and slowing down the proliferation of keratinocytes in the skin.